Alright, now let's get back to the herpes viruses, which we skipped before. Here is the list of the members of the herpes virus family. Let's start with HSV1. Most adults are infected with HSV1 acquired through salivary transmission, but which usually results in an asymptomatic infection. Initial symptoms may include vesicular ulcerating lesions of the mouth, aka gingivostomatitis, the eye, aka keratoconjunctivitis, or the hand, known as herpetic whitlow. HSV1 is the most common cause of sporadic temporal lobe encephalitis in the US, which presents with fever, headache, seizures, and altered mental status. HSV1 can be latent in trigeminal nerve ganglia and reactivate during periods of stress or immunocompromised states. Reactivation presents as herpes labialis or cold sores around the mouth. The virus travels retrograde from the ganglion to the skin. Do you remember from biochemistry which cytoskeletal motor protein assists with this? Right, dynein. Okay, herpes simplex virus 2. HSV2 is transmitted by sexual contact. Most infections are asymptomatic. I know you really want to see a picture of what genital herpes looks like, so okay, I'll oblige you. This is an image of genital herpes with blisters around the genitals. These blisters break and form tender ulcers. HSV2 remains latent in sacral ganglia and can reactivate under stressful conditions, resulting in genital lesions. Prevention of recurrences includes daily use of valacyclovir, acyclovir, or famciclovir. Enough of this image. I've put up the word torches on the screen. The torches infections refer to the mnemonic used to describe the collection of pathogens that can cause congenital defects when passed from a mother to a developing fetus. Highlighted here in red to help you remember is that HSV2 is one of the torches infections and can affect neonates, usually during delivery. C-section is indicated for mothers with active HSV infections to prevent transmission. Remember, HSV1 is for the mouth, HSV2 for the genitals. In situations of oral sex, however, these can be reversed. VZV infection is responsible for varicella, aka chickenpox, and zoster, aka shingles. In children, VZV causes a mild, flu-like illness with characteristic skin lesions described as dewdrops on a rose petal. Lesions start out as papules on a macular erythematous base that vesiculate, become pustules, and release viral particles during rupture. As you can see in this child, these chickenpox lesions will appear as multiple lesions at different stages of infection, so you'll see some papules, some vesicles, some pustules, and so on. These will typically resolve after a few weeks. Remember, this is different from how smallpox presents. VZV remains latent in trigeminal and dorsal root ganglia, with reactivation leading to a painful vesicular skin lesion known as herpes zoster, or shingles, which can be seen in this image. This usually happens in immunocompromised individuals such as the elderly. I would refer to the neurology section and review the distribution of cranial nerve 5, which may be a way the step 1 will test your knowledge of this cranial nerve. The key to diagnosing shingles is to look for painful vesicular lesions in a unilateral dermatomal distribution that doesn't cross the midline, as you can see in this image. Shingles is not only very painful but can also result in post-herpetic neuralgia. VZV infection in adults is much more serious and can lead to pneumonia and encephalitis. Therefore, it was well known that contracting VZV at an early age was more desirable to being infected as an adult. This reasoning formed the basis for chickenpox parties, where uninfected friends and classmates were encouraged to gather in one area and contract varicella from an infected child through contact with this highly contagious virus. Today, though, we have 2 vaccines against VZV, one that is given to children to prevent chickenpox, and another commonly known as the zoster or shingles vaccine, given to adults older than 50. This adult vaccine prevents shingles. It's probably far less fun than going to the chickenpox parties of the past. Next we have EBV. EBV is best known as the cause of infectious mononucleosis, better known as just mono, which has also been referred to as the kissing disease because it is commonly transmitted through saliva in teenagers between 15 and 20 years old. In mono, you will see fever, hepatosplenomegaly, pharyngitis, and lymphadenopathy. As a physician, you'll advise patients who are acutely infected that they should avoid contact sports because it can cause splenic rupture. Do you know how to diagnose an EBV infection? Diagnosis can be made in one of two ways. You can see atypical lymphocytes on blood smear or positive monospot test, aka the heterophile antibody test. In terms of the peripheral blood smear, of which I'm showing you an example here, you will see an atypical lymphocyte. EBV infects B cells. However, there is a trick question here. The trick question that is often asked on the boards is, what are the atypical lymphocytes? Are they B cells or T cells? Although EBV infects B cells, these cells on the smear are really cytotoxic T cells. This is because the T cells are activated because they are responding to EBV-infected B cells. So, this lymphocyte that you see here is one of the activated cytotoxic T cells. So let's go back to the other way to diagnose EBV, the monospot test. So what is the monospot test? The monospot test looks for agglutination of red blood cells from an animal, usually sheep or horse, when the patient's serum is mixed with these sheep or horse red blood cells. The EBV-infected person that was not exposed to horse or sheep red blood cells will form antibodies that react with the sheep or horse red blood cells. Note that once infected, you carry the EBV virus for life, that lie latent in B cells. Important to remember is that EBV is also associated with Burkitt's lymphoma, which is more common in Africa and is a type of non-Hodgkin's lymphoma. If you are unsure what that means, take a look at the hematology section. The tumors in Burkitt's tend to be in the face, as in this child. The solid tumor is actually composed mainly of aberrant B cells. The other cancer associated with EBV is nasopharyngeal carcinoma, often occurring in the Far East. One last malignancy EBV is associated with is in patients with HIV, where it can cause a primary CNS lymphoma. This is because EBV can cause cells to proliferate continuously, also known as immortalization. Cytomegalovirus, or CMV, is our next herpes virus. Key thing to remember are that it is the cause of neonatal infections, or the C in torches. CMV is the most common viral cause of congenital abnormalities in the US. In newborns, CMV can cause cytomegalic inclusion disease with symptoms such as petechial rash, seizures, hearing loss, and other CNS deficits. Also, it is often transmitted to transplant recipients. In adults, CMV can cause a disease similar to mono, but when you do the monospot test, it'll be negative. This is because no heterophile antibodies will be formed. The step 1 likes to test this, so remember, CMV monospot negative. Diagnosis is made by seeing infected mononuclear cells with owl's eye inclusions, seen here. You'll hear about owl's eye inclusions again in hematology, where they are seen in Reed-Sternberg cells in Hodgkin's lymphoma. However, in Hodgkin's lymphoma, the owl's eye inclusions are not CMV. It should be clear from the context of the question whether you are dealing with Hodgkin's or CMV based on the patient's symptoms. Make sure to keep this straight in your mind. HHV6 causes roseola, which is characterized by high fevers and a diffuse red macular rash, as can be seen on this child. The name of the rash is called exanthema subitum. HHV7 is a less common cause of roseola. HHV8 causes Kaposi sarcoma in HIV patients and results in angioproliferative lesions that are shown in this image. Do you remember which zoonotic bacterium causes a disease that presents with angioproliferative lesions indistinguishable from Kaposi sarcoma? Great job, you remember! It is bacillary angiomatosis caused by Bartonella henselae in immunocompromised hosts. You may recall that biopsy is needed to determine the causative agent. Let's have a final discussion on HSV identification. Your first choice is going to be a PCR, but the boards will like to ask you about the Chang smear. Chang is a buzzword. You hear Chang, think herpes. Chang smear identifies HSV1, HSV2, and VZV by looking for multinucleated giant cells found in these infections and which are shown in this image. Multinucleated giant cells are formed from the union of several cells such as macrophages. Just think, thank heavens you don't have herpes. Your third option is to do a skin biopsy. Key word here is the presence of intranuclear cowrie inclusion bodies, which are pathognomonic for HSV or VZV infection. This image shows cowrie inclusion bodies as a result of HSV infection. Flash quiz time again. I'm helping you drill this in. EBV will give you what? A positive or negative monospot test. What about CMV? You see, you know this. EBV will have a positive monospot, while CMV will have a negative monospot.